Assalamualaikum and a very good afternoon. I think this is always quite a challenge to give the last talk of the symposium before break. But my name is Fahmi. I'm from Gleneagles Medini. Thanks for the NRAS committee for inviting me here. But I have a confession. My talk is about fascial plane block for cardiac surgery. But because Dr. Woon has given such a great talk, she's covered most of my topics. So I think I can conclude my session here. Okay, if you want to go for a break earlier. Otherwise, I shall give a very brief talk about my experience sharing. Okay, I have no disclosure, nothing to disclose. Just a brief introduction. Basically, currently now, NRAS program has also been started for cardiac surgery, and part of the opioid sparing strategy also incorporates the regional anesthesia with multimodal analgesia. Traditional epidural and paravertebral have some concerns in cardiac surgery traditionally due to the heparinization and supposed hemodynamic instability. So that's why nowadays more cardiac anesthesia has moved towards fascial plane blocks. I think everyone know what fascial plane block is. Dr. Ng Zetek has already explained. Currently now is increasing in popularity in cardiothoracic surgery because it's a perceived lower risk, although it's not. It's only perceived, but it's getting more popular. Okay, again, I don't have to explain much about the anatomy because Dr. Woon has already explained about it. But mainly, the innervation of the chest wall is mainly from the intercostal nerves, from the ventral ramus, and also from the chest wall, also from long thoracic nerve, thoracodorsal nerve, and intercostal brachialis. There are few fascial plane blocks that has been described for cardiothoracic surgery, but in interest of time, I'm just going to cover these three major blocks, which are the ESP, Serratus Anterior Plane Block, and also the Parasternal blocks. Sorry. Okay. So if you look at the diagram here, the ESP cover the most proximal part, and then the Serratus Anterior is given towards the lateral chest wall, and the parasternal is used to cover the anterior chest wall. Okay, Serratus Anterior Plane Block is initially introduced by Blanco in 2012. Initially developed as a less invasive alternative to paravertebral block for breast surgery, and later on is expanded to thoracic surgery and also management of rib fracture pain. Current indication in cardiothoracic surgery includes VATS surgery, thoracotomy, and also minimally invasive cardiac surgery using thoracotomy approach. Okay, this is a general landmark. Normally, we give the block either superficial in between the latissimus dorsi and serratus anterior muscle, or the deep serratus below the serratus anterior muscle. Okay, this is how you perform. Normally, you can do it patient on a supine position at the 5th to 6th ribs, and if you do, the pointer is not really pointing. Okay, can either give a superficial SAP in between latissimus dorsi and serratus anterior, or deep SAP at the deep to the serratus anterior muscle. You can also, if the surgeon is receptive, you can also ask the surgeon to insert the SAP catheter surgically under direct vision. This is what I do in my practice. So before they close the chest, you can ask them to insert the catheter either deep to the serratus anterior muscle or above the serratus anterior muscle. Okay, how about Erector Spinae Plane block? Initially introduced by Ferrero in 2016. Initially described as analgesia for thoracic neuropathic pain. And nowadays, it's also has a rapid rise in popularity and now described in breast, thoracic, cardiac, abdominal, spine surgery. Indication in cardiothoracic surgery includes VATS, MICS surgery, thoracotomy, and also in the sternotomy cardiac surgery. Okay, normally this has been described in by previous speakers. We insert the needle just on top of the transverse process of the spine. Okay. Can either be performed in a sitting position, lateral or prone. You can either insert the needle caudal to cranial or cranial to caudal direction. And normally this will be explained later on tomorrow in our workshop, so I don't want to take too much time. But we normally do a sequential scanning from lateral to medial. We find the rib, which are a bit rounder and the pleura inside, and then you move medially towards the transverse process where it's flat, and you normally inject the local anesthetic at the plane beneath the erector spinal muscle. Okay. The next block is a parasternal intercostal plane block. It's traditionally been given blind by cardiac surgeon intraoperatively. Ultrasound approach is just introduced quite recently. There are two, which is now called superficial parasternal block and also deep parasternal block, just introduced in 2020. Indication in cardiac surgery is in sternotomy pain. The landmark is normally just about 2 cm lateral to the sternum, and you normally, for superficial parasternal blocks, you give at two level, at level or second rib and also fourth rib. But in the deep parasternal, you can get away with only a single injection. Okay, this is normally how you do it. In the superficial one, you give in between the pectoralis major and intercostal muscle. For the deep one, you give in between the intercostal muscle and transverse thoracic muscle. So what are the evidence? Currently, for the Serratus Anterior, there are few meta-analysis which shows that SAP improve early post-op analgesia, reduce opioid requirement, and also incidence of PONV in thoracic surgery. It's not used in cardiac surgery because normally it doesn't cover the sternotomy pain. For ESP, there are also some evidence in meta-analysis in thoracic surgery. It shows that it reduced pain scores, opioid use, and PONV as compared to control, placebo. And also, it seems to be quite comparable to paravertebral block in terms of opioid use, pain score, and PONV. In cardiac surgery, there was one new meta-analysis that investigate ESP and also parasternal blocks. And it shows that both ESP and parasternal blocks are useful in reducing morphine usage post-operatively. With the ESP is the most effective in reducing morphine usage. And ESP blocks is also associated with reduction of ICU length of stay. Okay, my personal practice in thoracic surgery, normally for VAT surgery, I'll give a single shot ESP block or superficial SAP block. If pleural disease, I use continuous ESP catheter. For thoracotomy or minimally invasive, using thoracotomy approach, and if the surgeon is agreeable, I ask them to insert SAP catheter surgically, or if not, I'll insert a continuous ESP catheter. Single shot loading dose, normally ropivacaine 0.375, 20 mils. For continuous block, I use program intermittent bolus with 10 mils every 4 hours. For cardiac surgery via sternotomy, my first choice is bilateral ESP catheter around T4, T5 levels. Second choice, if the surgeons are not agreeable or in interest of financial or time, I'll give a single shot bilateral superficial parasternal block at the second and fourth ribs. So single shot loading dose normally ropivacaine 0.375 20 mils each side. For continuous block, I'll give program intermittent bolus at 0.2% ropivacaine 10 mils every 4 hours each side. Okay. So in summary, nowadays fascial plane block is becoming quite important part of multimodal analgesia for cardiac surgery. And ESP, parasternal, and SAP block is quite a high value block in cardiothoracic. Perhaps later on, maybe a retro SCTL block will be one of the high value block as well. That's all. Thank you very much.